now we have Dr. Madhav Mutalik with us. He's a very good teacher. He worked in abroad. He worked in India. He taught to medical students, dental. So various medical students in different countries also he has taught. So an eminent personality with us. So we just wanted to get a few very important things about teaching and academic activities pertaining to the medical education in India and abroad. Welcome, sir. Welcome, Dr. Madhav, sir.
Welcome, good morning. Welcome, Mr. Nagesh. Nagesh.
Good morning, sir. Good morning.
Thank you for this opportunity.
Yes, sir.
Okay.
Straight away, I will move into the discussion, sir. As we have discussed that we are restricting ourselves to academic point of view. My questions mostly will be regarding academic only, especially regarding medical education. So I would like to ask you the first question is, what are the key points a teaching doctor should keep in mind while preparing for a class to a medical student?
Yes, a teaching doctor first has to know what is the audience to whom he is teaching, number one.
Okay.
And he should have what is called as some specific course objectives or learning objectives, which this level of student is supposed to know when the student becomes a doctor and starts practicing.
Okay.
So as far as the undergraduate curriculum in India is concerned of various branches, the teacher has to remember that he may be an expert in the basic science, or he may be an expert in the clinical science, but he is teaching a basic undergraduate course. So sometimes it's very hard difficult to decide exactly what is needed as a basic medical doctor, not as a specialist, not as a super specialist. Of course, there are guidelines and there is syllabus, but syllabus are the broad guidelines, what the person is supposed to know. But in that syllabus, exactly what are the points and what point should be omitted is the most important thing while the teacher is preparing. There is no point in showing how much knowledge or how much information you have, because all that information is already there on in various textbooks and various internet sites, and everywhere the knowledge is there, information is abundant, and there is overload of information actually.
Yes.
So I think rather than what to teach, what not to teach is becomes very important, and how it can be practically applied, how this person is really going to practically apply it when in the clinical science, when he is going to become a doctor and practice as a doctor. This is most important. So in single line, exactly what is needed for that level as a basic medical doctor, and what are the details which are to be avoided, and the details which may not be needed throughout his life sometimes, or there may be some details which will be learned at higher level, higher course level, when the person goes for post-graduation or something, then that person is supposed to know those things. So many times the lecture activity becomes complicated, becomes complex, because we don't have the exact plan, exactly what to deliver. So a nice good plan should be prepared for every class, and exactly what is needed should be taught, and what is not needed should be omitted.
So you mean to say first we should remember who are the audience, whether it is undergraduate student or postgraduate student. Then we should have our own objectives based on the curriculum given and the guidelines. Then
Yes.
we should also know what to be taught, what not to be taught, and what is more important,
Yes.
what is less important.
Yes.
Okay, that is really worth sharing this with the viewers also. What makes your lecture different from other teachers? What do you think in your point of view?
Yes. Please don't try to pose me as someone very different, or I will not try to pose me as someone very different. But what I mean to say is, number one is, in my opinion, in my view, a good lecture is one. When the lecture starts and the lecture begins and the lecture ends, the student doesn't come to know that the lecture has ended. That is a successful lecture, which means that you should be able to keep the attention of the student throughout the class. Let the class be a short one, but it should be sweet, and everything whatever we are saying should be understood, should be clearly communicated to the student. So many times I say that knowledge of the teacher is little less important than the skill of the communication, the skill of connecting with the students, relating with the student. And the student should feel that, yes, I am understanding everything, and then I'm going ahead. That is one. So what I feel sometimes I do things differently is, although there is a gross plan for the lecture and what information is to be delivered is there, but every time the starting of the lecture, the ending of the lecture, every time it may change. And a key word for this is spontaneity. So
Spontaneity.
if you definitely have a mechanical plan that first I'm going to say this, then I'm going to say this, then I'm going to say this, then many times it happens that the teachers go mechanically, and it becomes a kind of a dry thing. So to make it interesting, there are various medical education techniques which people theoretically know that this is to be done, that is to be done. There should be some story, there should be some joke, there should be some interesting examples. All this is theory, but the most important thing is whether it is practiced. So what I feel is, while going for every class, the teacher should either have something in his mind, some plan in his mind to do things differently. And usually people don't do these things differently because there is a fear. Number one. The second important thing is, we get used to it and we think it is a routine. So what is there in a lecture? And that is the saddest part, I think, in academics, is the people consider academics as a routine. People consider teaching or lecture as a routine. For me, it's not a routine. For me, every day is a new day. Every lecture is a new lecture. Every moment is a new moment, because it is new moment and there is different audience in front of you. So you have to judge your audience like an actor, like an orator, how the person judges the audience, and accordingly he has to develop the capacity to change himself and make the lecture spontaneous, as if the person should feel that this person is talking to me directly and he's talking to me right now, and it is a live session. So that kind of a feeling should be there. So I think usually I do it spontaneously. And although I have got all the basic material, everyone has got all the basic material and information, whatever is to be delivered, and there is a gross plan while going for a lecture. But when you actually deliver it, when you actually communicate to the students, there should be spontaneity. And spontaneity is the key word. If it is spontaneous, then it becomes interesting.
So I think you must have undergone the CBME also. Now the NMC or MCI has introduced a new curriculum to the medical education, CBME. So don't you think that CBME is emphasizing on these key points like communication, knowledge, and what you said, spontaneity?
Of course, this is what the CBME has kept the objective in mind, that all the skill, all the knowledge, everything should be coordinated and integrated. My point was how we deliver it. Finally, that is again a rough plan. That is there are specific things which you are supposed to do. But if you start doing these specific things mechanically, it will be like a robotic thing, and the human touch will be lost. So why some teacher is different than other teachers is how that actually is delivered. This is what I'm saying. And for this, it has to be practiced. In spite of having all the theoretical knowledge and doing all the workshops and being an expert in medical education, someone may not be a good teacher. I'll give you an example. If there is someone who knows everything about the automobiles and who knows everything about the cars and vehicles and everything, and he is an engineer,
Okay.
but he's an engineer, but suppose a car stops on the road and it doesn't start, then engineer may not be able to know and may not be able to start the car. That can happen. There may be another person who is a very good mechanic of the car, and he is with you. You are carrying him along with you, because he's a very good mechanic. If the car starts on the way, if there is some breakdown, then he can help you. That is fine. But suppose you are tired of driving, and if you request him, you drive the car, he may not be knowing the driving. That can happen. So many times theoretical things are in place, the system is in place, but the people who apply the system, they are most important. So whether you have the skill and the technique of delivering the curriculum is most important. The policy makers have done the guidelines, and you should use these guidelines, but the actual communication, actually relating to the students and making it interesting and making them realize that you are learning something real-time story of the patient. That's most important. And how you make it in front of the students and how you deliver it and communicate it is most important. So again, I am saying practicing it, taking risks of doing experiments every class, and working with spontaneity to make the class interesting. This is most important. Then that CBME will subserve the objectives which it has given.
Now,
I hope I'm clear.
through CISP, actually, this is being implemented everywhere throughout India. Do you think that medical education is mainly focusing on CBME to insist on the faculty? Are they not going to give any freedom during the delivery of curriculum as per CBME?
There is a lot of freedom. It depends. That's what I said. How you apply and how you utilize the
No,
CBME guidelines.
but what I heard
classes.
from the first year already, because it is already being implemented, 1 year is already over through CBME. What I heard is the feedback given by the many of the first year faculties are like it is so comprehensive, so the schedule is so tight, it is very difficult to manage. So we need to go at a very rapid rate to deliver the curriculum. We are forced to deliver the curriculum, not to deliver the knowledge or skill, whatever you are saying, very important, like spontaneity. All this is missing just because they are overburdened because of the tight schedule and because of early clinical exposure, self-directed learning. So many things they have introduced. It has restricted the time given for the teacher to deliver the actual content, the way what you are saying, like spontaneity,
Yes.
Story, making it interesting, making it a live session. This is all missing because of the tight schedule given by the CBME. What do you say, sir?
I think there are three aspects of the question which you have asked. There are three different answers.
Okay.
Three different factors. Number one, have we really understood what is the change than what we were doing in past? So sometimes there is a failure to accept the change, and there is a little bit of resistance to the change, and this resistance is also because we are new and we have not been used to doing it this way, and that's why we are feeling it different, and we are feeling that there is overburdening and there is shortage of time and all this. So as we will get used to it, again the practice is important. As we will get used to it, we will do it second time, third time, fourth time. Probably we will start understanding the pros and cons, and we will start understanding exactly how we are supposed to deliver, and we might improve ourselves. We have never implemented this kind of a curriculum past. So until we get used to it, until we get practice of it, this feeling is not going to happen. Plus, if there is a kind of resistance, that there is a prejudice in the mind that whatever we were doing was far better, and what is all this, if that kind of a feeling is there, then we are not going to learn. So that is one aspect which we must keep in mind, with due respect to all the teachers. Once we get used to it, we are going to do it in a better way, and whatever inhibitions we are feeling right now, they won't be felt. That is the first thing. Second important aspect is, are we really going into the depth of the CME, and are we really trying to understand why it is made in that way? And there are some things which are omitted. In the syllabus, those guidelines might be there, but the weightage of those things have been reduced, and the weightage has been given to certain other things. The weightage has been given to the clinical skill area. And are we really used to it, and are we doing it? We were doing it in past. We were doing everything in past. But now the CBME is telling you to focus on some definitive things. And unless we start doing it, we are really not going to understand, and we are not going to really overcome this inhibition. So this is the second part. That's why I said what is to be omitted. That is most important. We have not yet learned that few things are omitted, and we have got that inhibition. No, this must be taught, this must be taught, this must be taught. We have to overcome that kind of inhibition. This is second aspect. And the third aspect, going on the side of the teachers, I do understand that the time is short. And this is my personal opinion. Due regards and respect to all the policymakers, the higher authorities who have implemented this kind of a curriculum. About the quality of the curriculum and about the method of the curriculum, there is no doubt. But the question is the time factor. And my personal opinion is the basic paraclinical and preclinical sciences, the time which has been cut down, it should not have been cut down. If you really wanted to make a basic medical doctor in a nice way, then previously there was 1.5 years for preclinical course in the MBBS curriculum that should have been continued. And then probably whatever is the basic things, they would have been delivered in a better way. So this is my personal opinion regarding the first year medical subjects. So as far as that is concerned, the time duration is definitely short, is my personal opinion. I hope I'm clear on the
Yes,
three
sir.
aspects.
Yes, sir. So, in your opinion, again, CBME is good for the medical education or bad?
CBME is good for medical education, provided I said that the preclinical course should be of 1.5 years. And if you really wanted to pack everything into that and you wanted to go to the clinical exposure early, then why didn't you increase the duration of the medical course? The information has increased, the world has updated so many things, so many new techniques have come, so many new things have come in clinical science. But then why the medical course is still same 4.5 years and 1 year of internship? Why it is like that? Why not the medical course make the medical course of 5.5 years or 6 years? And then probably this time shortage is not going to be an issue. The second important thing is our incapacity to do the medical admissions in time. The 12th standard exam or the what you call NEET exam gets over quite early, and after that, if you just look at the time frame by which we make the medical admissions, almost 5 months, 4 or 5 months of the year are lost. And this is the basic problem which the preclinical teachers are suffering from, the first year teachers are suffering from, and then they have to pack everything during the course. Forget about the corona days, and I'm not speaking about that, but in general, the last person gets admitted in the MBBS class in the month of October, and he gave his NEET exam say sometimes in the month of February and March or April. And what is this time gap? And because of this time gap also, the students find it difficult to understand and to realize the things because they have been totally away.
What is your stand on non-medical teachers in medical education?
What do you mean to say? Non-medical teachers? They are medical teachers.
You mean to say non-medical in the sense it is a non-MBBS but teaching to medical students?
Yes, but the course which these people have done is MSc, right?
Yes.
So
MSc and MSc PhD in medical subject.
Yes, but it is MSc medical pharmacology or MSc medical biochemistry, right?
Yes, sir. Or medical microbiology. Now, what is your view about the reservation?
I don't feel that it is a non-medical course.
It is not a non-medical course.
It's a medical qualification, but you are not MBBS.
Yes, sir.
That's all. Yes.
So, does NMC or MCI should continue them in education, because there are so many policy changes have happened, like showing some bias over these non-MBBS qualified medical teachers?
The question you are asking me is a personal question, actually. Some person may have bias about medical teachers and some people may have bias.
Of course, as a professor and HOD of a pharmacology department, you can answer.
Yes, as a professor and HOD pharmacology department, if the person is a good teacher, then whether he is MSc or whether he is MBBS, it doesn't make a difference. If there is a difference, then probably there is some lag in the teaching. There is some deficiency in the teaching. These MSc people, when they are actually doing their MSc medical pharmacology and medical biochemistry, if their training is extensive and if their training is good and if the person is a good teacher, then this good teacher can deliver in an equal way. I have seen many MSc medical biochemistry or medical physiology or medical pharmacology teachers doing an excellent job. So that statistics again is same. There may be many MBBS medical teachers who are not good teachers. This also can happen. So basically, whether you are a good teacher or not, that matters. And have you acquired enough information and knowledge during your MSc course, and whether your training was extensive or not, that is going to decide.
So their competency will decide.
The competency will decide, basically.
Yes, sir. Another question. Have you done any work in medical education improvement? Like, have you worked for any guideline or any statutory body where you can make some policy guidelines for medical education?
No, I have not worked on any statutory body.
Okay.
I'm a medical education expert because I have completed all the required workshops, and I have been conducting sessions for medical education technology and health science education technology at various colleges and universities. I'm also working as a faculty resource person for Maharashtra University of Health Sciences, Nashik.
FAMER or ACME, have you done in FAMER or ACME courses?
No, I've not been on these bodies.
Have you made any videos suggesting the improvement in medical education?
I have not done any videos on suggesting improvement in the medical education, but I have done the videos of my own subject teaching, that is pharmacology, and I have also done videos on behavioral science,
Okay.
which is for undergraduates.
And
I
this
also have my own website called mutalikpharmacology.com, where the students can basic undergraduate pharmacology learning can become easy for the students.
and it is freely available and freely accessible
It is
to
freely. The www.mutalikpharmacology.com is a free website, and throughout the world, almost from 50 countries, more than 50 countries, almost 20,000 users are using this website.
Okay. So another last question, sir. What is the major difference you have observed in the students from India and students in abroad, other countries other than India? Is there any gross difference that you have observed?
The gross difference which I have observed is the students who come to Indian medical colleges, they get admission at the age of 17 or 18.
Okay.
And they are very young students. Because they are very young students, the positive point of this is the energy level.
Okay.
That's the first important. But at the same time, I believe that with age your maturity increases and your responsibility increases, and because the Indian students are facing sort of more competition, and they've got more avenues for learning, more avenues for going for super specialty as compared to the rest of the world. Education in India, although we say private medical colleges are charging so heavily, but still the medical education in India is expensive, and that is why probably we want to get out early, we want to get out fast, and our curriculum has been designed in this way that you get admission for medical curriculum at the age of 17 or 18. Abroad, I have observed age is no bar, and even a 25-year-old, 30-year-old also student also comes for medical learning, and there the person comes to take up a medical doctor course because he has got extreme passion for becoming a doctor. Here, as far as the intake criteria is concerned and the reasons for taking admission to a medical course is concerned, there may not be every time an extreme passion, an extreme wish and will to become a doctor. It may not exist. And as teachers, you and me, we have been seeing that many students are forced into the medical curriculum for various reasons. So these are some basic differences. And there, because I've seen many students, they got admitted in the medical course at the age of 23, at the age of 30, at the age of 35. And because the person takes it up because he wants to take it himself, the people are more devoted, and they've got more responsibility of working as compared to the Indian students. And it is very obvious that when you are 17, 18 or 19, naturally you are on the verge of your adulthood, and that is why, although we call adults, they are on the verge of adulthood, and that's why many times the teachers have to do a kind of spoon feeding type of a thing with students, and the teachers have complained that students don't do this, students don't do that. There I think if the age is more, the sense of responsibility is more. This is a sort of difference.
So, but you said medical education in India is expensive. Even in government colleges also you feel it is expensive?
Government college, see, it is very difficult to compare strata by strata as compared to the countries. But I am saying in general.
In general.
Mm.
Oh, it is. But many people are coming to India.
I didn't say expensive. I said it is less expensive.
It is less expensive. Okay.
less
It
expensive.
is less expensive. Okay.
There, if you want to become a medical doctor, there is huge expenses.